This recording will go over emergency and trauma nursing. Some of the topics that we're going to cover is the emergency department environment and vulnerable populations, prioritizing order of emergency department care via triage, which is classifying patients due to your level of concern or their level of acuity into classifications of emergent, urgent, and non-urgent based on assessment of the injured or sick patient. We're going to talk about primary and secondary survey, which should be reviewed to you, and also talk about what disposition is for a patient. Patients come to the emergency department for treatment of illness and injuries that range from minor to life-threatening. Patients could come in with anything from an ingrown toenail that's super painful to being in cardiac arrest. Treatment in the emergency department occurs regardless of the ability to pay, so we don't stop the patient at the door and ask them about their insurance or have them set up a payment plan. It also occurs regardless of citizenship, so a sick patient comes in and they're going to get treated regardless. In the emergency department, we have to be mindful of vulnerable populations and be sure to promote trust and maintain or monitor safety precautions, which you probably covered last semester in mental health. When you think about your own safety in a situation and ensuring patient safety. But vulnerable populations is a term you should have heard already. So when you hear that, what do you think about? Maybe some of you are thinking about homelessness, people with drug problems, patients who are older or incapacitated for any reason, and patients who have mental health needs. Become a nurse, they said. It'll be fun. Triage is a term that most students have heard about, but sometimes don't understand what exactly it means. So the definition is an organized system for sorting or organizing patients into priority levels, depending on illness or injury severity. And this little picture sums it up for you. Waiting is good. It means you're not going to die. The person you need to feel sorry for is the one who gets rushed into the ER and treated first. So triage is classifying patients. Basically, if you're going to die quickly, you're going to die first, you'll be the first one we see. If you're going to be fine sitting for 24 hours, you have an ingrown toenail, you'll be the last patient that we see. So there's different classifications based on the severity of the patient's illness or their acuity. And another little pick for you, the triage nurse, being worst makes you first. We're going to learn about 3-tiered triage system. So the patients are going to be categorized or classified as either emergent, urgent, or non-urgent. With the emergent patients being the patients that we're going to bring back quickly, assess, get the labs, diagnostic studies, everything done quickly for them. And the non-urgent patients being the patients who can wait the longest. So urgent triage category implies that a condition exists and it poses an immediate threat to life or limb. And some examples of emergent or life-threatening conditions include chest pain, hemorrhage, respiratory distress, stroke, and vital sign instability. The urgent triage category indicates that the patient should be treated quickly, but that an immediate threat to life doesn't exist. And it includes severe abdominal pain, displaced or multiple fractures, renal colic. That might be a new term for you, renal colic. So what organ system are we talking about with renal? Kidneys. And colic, maybe you've heard of a colicky baby. It's really cries a lot. It's in pain, usually associated with gas. But in this case, renal colic, we're talking about kidney pain. So it could be kidney stones likely. Also classified as urgent, respiratory infection, especially pneumonia in older adults, and soft tissue injuries, whether they're complex or multiple. Patients who are classified in the urgent triage category can wait a while, but they may need to be reassessed if it's taking longer than we expected to be able to pull them back, because we don't want their condition to change and the patient be out in the waiting room and no one have an eye on them. Lastly, the last classification is non-urgent triage, in which the patient can generally tolerate waiting several hours before healthcare without any significant risk for clinical deterioration. So they're not going to get worse as they're waiting to be seen. And some examples of that include simple fractures, rashes, strains and sprains, and UTIs. You need to be familiar with the term disposition. You've learned from your first semester that we start planning a patient's discharge upon admission. So disposition is a term, and it just stands for where the patient should go after discharge from the emergency room. So are we planning on sending them home? Are we planning on sending them to a hospital that's better equipped to handle their needs? Are they getting admitted to the floor? What is their disposition? The primary survey is an organized framework used to rapidly identify and effectively manage immediate threats to life. The primary survey is typically based on the standard ABC mnemonic plus D&E. So you've already learned about your ABCs when you learned about prioritization with NCLEX style questions. So the A stands for airway, making sure we have a patent airway. B, breathing, assessing lung sounds, watching for chest movement, respiratory effort, respiratory rate. C, circulation. So how would you assess your patient's circulation? Hopefully you're thinking about heart rate, blood pressure, cap refill, feeling if the skin's warm, looking at skin color. Interventions for circulation could include CPR, hemorrhage control if they're bleeding, getting IV access and administering blood or medications that could help bring up a blood pressure or vice versa. Worth noting, you've learned in your first semester course about how to assess a pulse, a radial pulse, femoral pulse, and a carotid pulse. When a patient's super sick, or maybe they've hemorrhaged or they're in shock, sometimes we can't feel that radial pulse, even though the heart's still beating, and they do indeed still have a pulse. And sometimes that's when we'd go in a very sick patient and check their carotid pulse. And the reason why is we can feel the carotid pulse at a lower pressure. So the radial pulse, the patient will have a systolic BP of at least 80 for us to feel. For the femoral pulse, the systolic BP would be at least 70. And the presence of a carotid pulse should be palpable with a systolic BP of at least 60. That's our ABCs. D and E might be new for you. D, I don't know. They call it disability, but it stands for neural. Okay? So you got airway, breathing, circulation, brain. D is brain, D is neural. And basically, disability examination provides a rapid baseline assessment for neurological status. The mnemonic for this one is AVPU. Are they alert, responsive to voice, responsive to pain, or unresponsive? A common way for determining and documenting level of consciousness is to use the Glasgow Coma Scale. For the Glasgow Coma Scale, you're going to assess your patient's eye opening, verbal response, and motor response. Now, you don't have to memorize the numbers that go along with each of them, but you can see you have a total score of at least 15 here. So 15 would be a good score. If the patient's Glasgow Coma Scale number changes by 2 points or more, that would be considered clinically significant. So let's say you go and assess your patient, and they are, have their eyes open, they're oriented to time, place, and person, they obey commands, they seem just like you are right now. They don't have any big issues. So you document this within the EHR, and they have a rating of, 15 on the Glasgow Coma Scale. And let's say an hour later you come back and you have to sternal rub them, right? Cause pain to get them to open their eyes. They're confused. So that gets us to 6. And they're only moving when they have pain, when you're causing pain to them. So that puts them at 11. So they went from a 15 to an 11. That's clinically significant, right? That's a big change in how that patient would be presenting to you. So if we have a 2-point change in the Glasgow Coma Scale, that would be clinically significant, meaning you need to call the doctor. Something's going on, right? 15 is the highest number they can get. So I'm trying to tell you the things you need to know about the Glasgow Coma Scale. 15 is the best score. You're good. 2-point change is important. Tell the doctor. And what are we assessing? Eye-opening, verbal response, and motor response. All right, we've gotten through A, B, C, D. Last one is E. The final component of the primary survey is exposure. If evidence preservation is needed, hand out items per institutional policy. Evidence could include articles of clothing, impaled objects, weapons, drugs, bullets. I was once in the emergency room and a woman came in. She said the bullet that she had been shot with that was lodged in her buttock was coming out and it was really painful for her. And the doctor was sort of like, meh, I don't think so. You know, maybe she has some sort of a little pocket of abscess or an infection there or whatnot. But indeed, she was correct. He was able to open it up and remove the bullet. And what happened to the bullet? Did we throw it away in the sharps container? No, we did not. A nice police officer came and picked it up as evidence. But aside from taking away evidence that might be needed, exposure is about exposing the patient. So by removing their clothing, you can have a more thorough assessment. So you've sort of looked at your emergency needs with ABC, followed up with D. Now, okay, you got that under control. You're going to expose the patient, remove their clothing. Is there anything that we've missed? Okay, so our primary surveys A, B, C, D, E, airway, breathing, circulation, disability, which means neuro, right? And E for exposure. After our primary survey, we can move on to a secondary survey. The secondary survey occurs after the nurse or the healthcare team has addressed the immediate life-threatening concerns or done any other activities that the emergency nurse can anticipate might be needed. They can then do sort of follow-up care. So maybe the patient needs an NG tube. Maybe they need a Foley catheter inserted. Maybe they need prepared to go get a CT scan. A more comprehensive head-to-toe assessment is known as that secondary survey. And that's when we can identify any other injuries or medical issues that might need to be managed. So we could put splints on the patient or put dressings on wounds. That would be considered part of the secondary survey. So we've looked at our primary focus with our primary survey. Now, okay, we feel like those main systems that are keeping the patient alive are okay. Now I'm going to move to a secondary survey, and are there other less threatening to life issues that I need to address with my patient?